Hello, and welcome to the care map updates that are going to be placed on the Shared Health website starting June 27th. So this is just a quick overview of some of the updates that are be done. Along with this, there is the updates to the hypoglycemia care map as well as the trauma bypass care map. Those videos are available on the YouTube channel. I won't be covering those with this video. Those are separate, so they are available if you want to watch them. So for the care map updates here, there's not going to be giant dramatic changes, but we are going to cover some of the things that are going to be updated here. So the first one is the creation of D01.2 labor IFT. So this is a new care map that's going to be added. So indications for this care map here is an IFT of a patient in labor. So this care map was designed by the medical directors because, to be honest, we're having issues with hospitals dumping patients in labor on us and delivering in the field. Ideally, we want to keep these patients if they're going to be delivering in the facilities and then transport the neonate, as opposed to having two paramedics on the side of the highway trying to assist a mother deliver her child. So there's really no contraindications care map. If you're not doing a IFT for a patient in labor, we're not going to access this care map. So the big one here is delivery imminent. So, a little obstetrics view, but delivery should be considered imminent. If the patient informs you that they have to urge to push, bear down, have a bowel movement. So it's just telling you that the baby's on its way. So if you actually do a physical inspection, so this ideally should be done by the sending facility before they call us in for the IFT. But if on physical assessment, there's bulging of the perineum, there's crowning, obviously the baby's on its way, we're not going to be transporting that baby. So, in the big red box, like I said, we're not going to transport a mother that's in active labor and the baby's on the way. Obviously, it's safer to have the baby in the facility. I know a lot of hospitals aren't set up for obstetrics, so they don't want to deliver the baby in the facility, but obviously it's much safer to be doing it in a facility than on the side of the highway in the back of an ambulance. So we're not going to transport. And then before we do transport, though, we are going to call online medical. So if the sending facility is like, whatever, just start going, we're going to call online medical for this, and they're going to talk to the physician at the facility and say, no, we're going to stay in facility. We can transport after based on our assessments. The other nice side about this as well is that if you're expecting that the mom's going to deliver at any moment, online medical along with vectors and the transport physician, they can all start talking on the side while we're helping with the delivery of the baby. And set up neonate transport team, possibly like obstetrics staff on the STARS helicopter based on what's available. And online medical can help set that up while we're assisting in delivery, which again is much, much safer and a much better use of resources than trying to deliver a baby on the side of the road. So even if delivery isn't imminent, if the woman is in labor, so again, it may not be as like the baby's almost out kind of labor, but it could be progressing quite well. We're still going to call online medical before we transport, because the online medical physician wants to talk to the sending physician to, again, make sure it's safe and practical for us to be transporting these patients. So with that, the online medical physician is going to want to know the following, and this is all in the care map here, but they're want to know the gravida and para of the mother. So with that, gravida is the number of pregnancies, and para is the number of times they've actually given birth to a viable child. So they also want to know what's the gestational age of the pregnancy. So this might be difficult because not everybody has obstetrical checkups. They don't get prenatal care. So if you don't know, you don't know, and don't just like assume. Like if the physician at the hospital states that we think they're this far along, you can relay that information, but don't just guess numbers. If you don't know, you don't know, and just tell online medical that. So is there one or multiple fetuses? Because again, this can put the patient at risk and the babies at risk, that if we're in the back of an ambulance and they're having triplets and all of a sudden 3 babies are out and we're by ourselves and our closest truck is an hour away, it's going to put a lot of people at risk. So that might be an issue with transport. So is the patient having regular painful contractions? And if so, how far apart are the contractions? Again, this is going to kind of give us an idea. So if they're having regular contractions and they're like 20 minutes apart and it's not really regular, they're probably not at a high risk for popping out a baby on the side of the road. Whereas if they're like a couple minutes apart, they're very forceful, that's going to make a big difference for transport decisions. So if you've never done this before, to actually determine the how far apart contractions are, you're going to start counting at the beginning of one contraction, and you're going to stop counting until the beginning of the next contraction. And then whatever that timeline is, that's how far apart the contractions are. So what has been the duration of previous labor? So a lot of times when mothers are in their first delivery, it takes a lot longer to deliver the baby. If they've had multiple deliveries before, it tends to be a little bit quicker, just statistically that any babies after the first one, labor tends to be shorter. So we need to talk to the mom about that, because if she has delivered a lot of babies, it's good to know. And if all of them, she's like, oh yeah, I guess I go into labor very quickly, but all my kids have been out within the first hour of labor starting. That's good to know, versus like, oh yeah, last time my last baby, I was in labor for like a couple of days. So those are good things to know for transport options as well. So again, have they had any prenatal care? Like, are we expecting any complications? How's the baby's cord placed? How's the baby placed? Like, are we expecting any issues with the placenta? These are all good things to know as well, because we're suspecting that this is a patient that's at high risk for any kind of like postpartum hemorrhage, things like that. We may want to stay in the facility, just to have extra hands to help us deal with possible complications. So the other thing you want to ask, and again, this is going to be at the facility physician that we're going to have them examine the patient. We're not going to do this. We're going to get the physician, and you can ask the physician if they've checked this as well. Have they had a vaginal exam in the last 30 minutes, and who did it? Obviously, we're not doing that. If there's no doctor, and that's why they're calling us, it's nurses, we can ask the nurses if they did it. And if no one's done it, again, just relay that information online medical. If we don't have the info, we don't have the info. So the other thing as well, is there water broken? So are the membranes ruptured? And is there any meconium in the amniotic fluid? So when we look at just regular amniotic fluid, it's more of a clear tinted yellow colored fluid. Whereas when we're worried about meconium, the fluid will have more of like a brownish tinge to it, greenish brownish tinge, as the baby's having bowel movements inside the uterus there. So with that, it's more common later on in pregnancy. So if the mom's past their due date, there is a higher risk of amniotic fluid in the uterus there. If it's earlier on, it may not be present, but that's definitely something of note. And the big one, how long does it take to get to your destination facility? So if you're further north and you're going to go to HSC Women's and you're looking at a 2-hour drive, that might be a factor as well, especially if the mom's contractions are very close together. We may not look at transporting, because we know for sure that is a good bet that they're going to deliver en route. And are there enough qualified personnel available for the IFT? So if you're able to take a nurse or not, if you can take a nurse and a doctor with you or not, if it's going to be 100% just one paramedic by themselves in the back, that can be concerning as well. So that can determine if you're going to send this patient out for a transfer or stay in facility. Is it any other trucks available? Again, if your next closest truck is an hour and a half away, just based on geography, that might not be an option. So we might have to look at other ways, like helicopter, things like that. And if you're going to be going, is there anywhere you can stop on the way? So are other hospitals open or closed? So we have other obstetrical hospitals. So like, for example, in East Zone here, we have Selkirk's technically obstetrical hospital. So if we're going to be driving right by it, we can say, okay, well, it's mom's in labor, but if something comes up, we can always stop in at Selkirk on the way to the city if we have to get redirected. And this is all stuff that online medical is going to want to discuss with you. So just have this all in mind, that we're going to do this history before we make this phone call. Don't be calling online medical and asking these questions to the mom while she's in labor with the doctor on the phone. So make sure you check this info first. So again, if we're transporting and we're starting to go in different zones now, we're going to the south, west, stuff like that. So there's a list in pretty much every obstetrics care map on actual obstetrical facilities available in Manitoba, and also for a few outside of Manitoba as well. So if you're not sure where you are, you can always ask dispatch, or you can just look into the care map and say, okay, we're going to be driving by Polaris Prairie on this transfer, so that's an option for an obstetrical hospital. So other things as well is what is the name and contact info for the sending and receiving healthcare provider? So they're going to want to know who's accepting your patient and who's sending your patient, because if the physician's like, oh, there's no one accepting this patient, we just want them out of here, that's a bit of a red flag. So we're going to want that information as well. If they've been accepted by, like, say, Women's at HSC, that's great. Here's the doctor. Great. Maybe our doctor can talk to their doctor and see what options are, and make sure everybody's on the same page before we send this baby out. So at the end of the day, either way, if mom's in labor or not really in labor, she's not like ready to deliver right away, does online medical authorize transport? If the answer is no, we don't transport. We stay in the facility and we proceed to assist mom with the hospital staff to have her baby. And then we still want to consider contacting online medical before transporting after the baby's postpartum. If the online medical does authorize the IFT, so you're just going to transport as we normally would, with monitoring your patient, making sure you're checking mom, checking your times of contractions. We can ask if we can get another healthcare provider to come along with us, such as a nurse or if physician, if available, and just in case the baby is born en route. And before the baby starts being delivered, you should probably get all your gear together. So make sure in the back of the ambulance you have your equipment ready, such as like towels, blankets, your obstetrical kit, resus stuff. So get out your size 1 eye gel and your infant BVM, just in case things go sideways, you're ready to go. You're not digging around looking for the appropriate equipment while your newborn's not breathing. So try to get all your stuff ready before you leave. So if labor rapidly progresses while en route, you may have to redirect to a non-obstetrical facility, and they should be there to help you. And the big thing is that childbirth is it's a natural thing. It doesn't have to be medicalized. So really, we're just there to assist the process. But if you need help, you can absolutely pull into an ED. The staff there should be able to help you. And if there's any issues, you can always call online medical. So even if the closest facility is on bypass and you're like, we need to stop, we need to come in, we need a couple nurses to help us, we're not offloading, all that good stuff, you can call online medical. So just like as CareMap B02 for redirection advisory, we can get online medical to talk to that facility's physician to accept our patient and help us out. If you're, just a side note, if you are close to Winnipeg, so you're getting close to the perimeter and mom's actively in labor, baby's coming, we can always ask dispatch to contact WFPS and ask for city ambulance intercept as well. We can work with them so they can come show up and help us out in the back. So with labor IFT, they threw a couple things in here for consideration for transport. So after 20 weeks gestation, a pregnant patient may experience supine hypotension when they lay down, and this is caused by the size of the fetus, just basically pushing down on the vena cava and reducing blood flow return to the heart. So this can cause issues for moms such as syncope, hypotension, all that good stuff there. So with that as well, there may be your patient may be suffering from bradycardia due to increase in vagal tone because of that pressure put on the vena cava as well. So if you're transporting and all of a sudden your patient starts bradying down, she's getting dizzy, lightheaded, it may be because the baby is putting pressure on her vena cava. So with that, we want to elevate the right hip 4 to 6 inches. And again, this is something we can actually prep before we load up the mom, start going. So if we're on the stretcher, so even in ACLS and BLS, they talk about this, where you may want to put a pillow or a blanket roll underneath the right hip just to elevate it, just to keep the baby off that vena cava and stop the chances of them reducing blood flow because they're compressing the vena cava. So there's also an option of manual uterine displacement. And again, this is in BLS and ACLS and stuff as well. So if your patient does develop hypotension while you're trying to get her hip raised, we can actually manually displace the uterus to the patient's side, as you can see in the pictures here. So we're just going to manually push the baby over to get them off the vena cava to help improve blood flow while we're setting up a blanket, because obviously we're not going to transport the whole way to the city holding onto mom's belly. So we want to just move the baby over, get that blood flow going. So hopefully reduce that hypotension, reduce that bradycardia, and then we'll set up something underneath the right hip. So there's a pillow, blanket roll, like I stated, just to get the improved circulation to mom. And that's labor IFT. Again, a lot of stuff isn't things we're not doing anyways. It's just now with the labor IFT, they're very adamant that we contact online medical before we transport any patient in labor. Just to make sure it's safe for us and it's practical for us to be transporting these patients, and safe for the patient too, because at the end of the day, we're going to end up with 2 patients to deliver on the road. And if we're by ourselves in the back, we can't really handle that effectively. So we want to make sure it's safe for everybody to get proper health care. So for acute coronary syndrome and STEMI, so this one's been updated as well. Again, there's not a lot of drastic changes, but there are some changes of note, and that's why we're going over them right now. So indications for this, for acute coronary syndrome is chest discomfort, pain, pressure, heaviness, symptoms consistent with ACS. So again, we're suspecting heart attack. We're going to access the heart attack care map here. So things to keep in mind is that when it talks about discomfort, some patients may not present with regular pain like other, as per the textbook, with that left-sided chest pain down the left arm. So patients like diabetics, geriatrics, patients, we need to consider that they may not feel pain the same due to like nerve damage, or just medications they're taking may not allow their body to react appropriately or respond. So if they're on beta blockers, things like that, it may not allow their heart rate to go up. So let's look at this nice regular heart rate, but they're having a lot of pain. So it may alter or mask symptoms that you would see with ACS. So have a high suspicion, especially like patients that have altered LOC, you rule out your blood sugar, you're not sure what's going on, check their heart because it might be having a cardiac issue causing blood flow issues. Syncopal episodes as well, those are always concerned. So anything like that, we always want to have a high suspicion for ACS. So again, so contraindications to this care map, there's really none because if we're not suspicious of a heart attack, we've ruled it out, we're not going to access this care map. So the first thing, as per like it hasn't really changed, is that can you acquire an ECG within 10 minutes of arrival? So when we look at stroke bypass, the window opens when onset of symptoms. So again, with ACS, it's when we arrive on scene. So the clock starts ticking once EMS radio's in, we're on scene. So you have that 100-minute window. So ideally, if you're suspecting ACS, obviously if the patient's not breathing, we need to deal with that first, but they want you to try and get your 12 lead done within the first 10 minutes of arrival because the clock is ticking. So when we're doing our 12 lead, just a quick review here of lead placement. This is really important. We want to make sure the leads are in the right place. We're doing proper skin prep. We want to make sure that we're going to be reducing the chance of lead faults, things like that while we're doing this 12 lead on the sick patient. So make sure the chest is shaved, dry it off, because if your electrodes are sliding off your patient because they're so diaphoretic, we need to dry off their chest. And make sure you got good new pads that have been sitting out, like sitting on the shelf for the last month, because that electrode conducting gel on the EKGs, if that dries out, it's not going to read properly, and that can cause lead faults and slow down your care. So just a quick review here. When we look at our 12 leads, we want to look V1, so it's the fourth intercostal space on the right side of the sternum, and then V2, it's the same, but just on the left, so for that fourth intercostal space. The next one we're going to do is V4, which is the fifth intercostal space, the midclavicular line. So the thing we have to remember is that when we start getting in V4, V5, we may have to move like adipose tissue, breast tissue out of the way. So make sure you clean the area. And just based on anatomy, if you're not able to get it on the fifth intercostal space, so try to get it as close as you can. It's recommended that we try not to put the electrodes on the ribs because that can affect how they read and basically dampen the conduction of electricity into the leads to read it. So just try to get as close to that spot as you can based on the patient's anatomy. Do the best you can do. So after we've done V4, we're going to put V3, and that just goes straight between V2 and V4. V5. So some people like to do V6 and put V5 in between V4 and V6. That's not wrong. Or you can do V5 goes into the fifth intercostal space, anterior axillary line. So basically when you look at the armpit, you go straight down where the armpit starts at the joint of the shoulder there and go down to your fifth intercostal space, and that's V5, and V6 is your fifth intercostal space, mid-axillary line, so in line with the armpit. Again, all the way around, we got to make sure we cleanse the skin, make sure it's clean, wipe off all the boob sweat if there's any like dry powders, things like that. If they've got large amounts of adipose tissue, we're going to have to lift up the folds and put it underneath as well. So we want to make sure it's in close to the proper position as possible. So with the 12 lead there, and then if you need to, you can do a 15 lead. So posterior leads are recommended to do a 15 lead because we want to get a full 360 of the heart. So your 12 lead does do the vast majority of the heart, but it doesn't get all of it. So we want to make sure that if we are doing a 12 lead and it comes back as, nope, they're fine, but your patient's presenting like 100%, yeah, this is totally an ACS patient. I've seen enough of them. I'm highly suspicious of ACS. We can do a 15 lead to check the rest of the heart. Also, if you have any elevation in the inferior lateral leads, so like V5, V6, leads 2, 3, AVF, we should do a 15 lead as well to see the extent of the damage, because that means there's possibly right-sided involvement. So we want to make sure we check the full right side of the heart by doing a 15 lead. So with this here, we're going to move some leads around. So V8, so you're going to take lead V4, and we're going to move it to the right. So with that, your V4 goes from the left side of the chest, and we're going to move it to the right. So that becomes V4R, so V4 on the right side. And then we're going to take V8 and V9, move them to the V5, V6, sorry, and we're moving them to the back, and they become V8, V9. So V5 is going to move to the back and become V8, and that's the fifth intercostal space in the midscapular line. And then we're going to take V6 and move it in between V8 and the spine. So we're going to find that midline, and that's where we're going to put that, and that becomes V9. So before we do our 12 lead, again, we put our electrodes all in the same right places. We're going to make sure we're good for the reading there. And then we're going to make sure on the Zoll we put in the patient's age and sex before you do your 12-15 leads. The reason for that is the Zoll will look for different ST elevation based on the patient's sex and their age. So we want to make sure that's looking for the right J point elevation, because for men it's higher than for women. So if we don't change it to female on the Zoll, they may have ST elevation, but the Zoll's still going to say no because it's not high enough to diagnose. So just something to keep in mind there. But yeah, you definitely need to do this before you take your picture. So we push a 12 lead and the 12 lead comes back and it says STEMI. So with discussion of the cardiologist at St. Boniface Hospital, they now want us to only call in if it specifically says STEMI with the stars. They don't want us calling anymore for like lateral infarct, stuff like that. Also, left bundle branch block is not on the list anymore. They straight up just only want us calling if the Zoll specifically says STEMI. So that's kind of a big change there. If you have concerns otherwise, if it doesn't say STEMI and you think St. Boniface is a better place for your patient to go, you're free to call Line Medical and ask for redirect. Just that way, at least they're going to the right cardiac hospital. So that's an option now. But again, they only want us calling it. Cardiology only wants us calling if it straight up just says STEMI on your Zoll. So if your Zoll does say STEMI, we're going to contact dispatch and ask them for the name and the phone number for the STEMI physician. So when you call them, you want to make sure that you know your patient's name, age, gender, time of onset, their relevant medical history, medications, allergies, current vital signs, all that good stuff. So basically what your patient assessment found. Also make sure that if you are going to send pictures through your phone, so if you text pictures of your phone to the cardiologist, make sure there's no patient information available. So that way, if you accidentally put in the wrong number and it gets texted to the wrong person, there's not a fee breach because we don't know those identifying factors. So with that, if the monitor does not stay STEMI, or the STEMI physician says, no, I know yours all saying this, but it's not a STEMI, it's reading it wrong. So with that, we can look at giving ASA. And again, with giving ASA, that might be done by your partner concurrently while you're doing your 12 lead, which is not wrong. Just give them ASA as per medication profile M37.1, and you can consider nitrates and opioids. Again, if you think it's safe to do so. If they're having right ventricular involvement, we may not want to give them nitrates because that can drop blood pressure. Same thing with using opiates. If you are going to use a opioid for pain control, again, fentanyl is the preferred for cardiac. It's been shown in studies that morphine can actually worsen cardiac damage during a heart attack versus fentanyl, which is less likely. So kind of use your own discretion there. But again, just as per new studies, fentanyl is kind of the go-to for cardiac. If you do give nitrates or opioids and they become hypotensive, we should have an IV line in place first, and then we can just give them a fluid bolus, but very cautiously because if their heart's damaged, they may not perfuse well. So we just want to carefully give them some fluid to bring up their blood pressure. And then we're going to transport. If the STEMI physician does say, oh yeah, this guy's having a massive STEMI, they're going to want to know your transport time. So can you arrive at St. Boniface within 100 minutes? So realistically now, especially for our zone, even if you're outside 100 minutes in our zone, they still want you to call St. B, and then transport decisions can be made with the STEMI physician. So it used to be if you're outside 100, you don't call a STEMI physician. For our zone, because we are reasonably close to the city, that they want you to call no matter what. So if it says that STEMI, we call St. B. Doesn't matter if you're past 100 minutes, but the cardiac physician is going to want to know that. So if you are within 100 minutes of St. Boniface and the physician tells you to come to St. Boniface, go to the cath lab, they may say, yeah, come to St. Boniface. The cath lab's really busy, just checking in at the ER and tell them we told you to come here. That's an option as well. Because I know there's been a few calls where people have gone and they've gone to the ER because the cath lab's just overwhelmed. They're like, we can't see them anytime soon, but bring them to the ER and we'll get to them as soon as we can. So that might be an option as well. So transport as directed. You can also give ticagrelor and enoxaparin as per M37.2 and M43, and these are only given on recommendation by the cardiologist. You don't just automatically give it if it says STEMI. You need to get authorization from the cardiologist before giving those. So if you can't arrive to St. Boniface within 100 minutes, we're going to consult transport physician there. So if the doctor's like, yep, this is a STEMI, you know what, do what you can. We can then contact dispatch and request a transport physician. Even if you're outside the range of the STARS helicopter, which most of our zone, the helicopter can reach. It's one helicopter, may not always be available. The transport physician may talk to the STEMI physician and determine reperfusion strategy and transport decisions and talk to you. So the STEMI physician may decide the patient still should go straight to St. B. Again, maybe not to the cath lab, but to the ER if you're outside 100 minutes. And then the transport physician can see about getting possible air intercepts if that's a possibility or not for you, so you're not driving the whole 2 hours to Winnipeg. So with that, if you or you can do your T&K checklist. The physician may direct transport to a local ER for this therapy. So training of the checklist done, and they say, okay, we'll go to the closest hospital, get the T&K going, then carry on down the road and come to St. B's. So ideally, if this is the plan, you're going to stay with your patient. You don't dump them off or transfer care to the hospital. And with the physician, then take off. They start the therapy, and then you continue on down the road. Again, this is all conversations on the doctor's side that they will inform us of what the plan is. So your T&K checklist, this is in the care map here. So these are things we want to ask. And again, it's basically just a list of questions, questioning the risk of bleeding out from this patient. So we want to make sure that there's no risk that if we give this med that they're going to start bleeding out internally. So we're going to transport as directed. And again, make sure to contact the receiving facility that, yes, this patient's been diagnosed with the STEMI, and we're just coming here as per the cardiologist. If they come in and say, why aren't you just going straight to St. B? They're having a diagnosed STEMI. Just say, as per the cardiologist, we are to go to the closest facility. And then they can arrange an IFT later on if they want. So if you haven't done so already, because you're on the phone a bit talking to a few different doctors, if you haven't given ASA yet or any kind of pain control, then feel free to go ahead and do that now. Again, keeping in mind, we're worried about blood pressures, all that good stuff. And again, enoxaparin and Ticagrelor as per the cardiologist, if that hasn't been done already as well. And that's it. So the big changes here really are that calling outside the 100 minutes, that's acceptable now. It may not guarantee that you're going to go to St. B, but at least when you go to your closest hospital, you say, yeah, this person's got a STEMI. It's already been seen and confirmed by the cardiologist St. B. This is what's going on. Other things as well is that when it comes to this, we only call in with the STEMI. We don't call in for bundle branch blocks anymore or any other kind of MIs. It's just only if the ZOL says STEMI with the little stars. That's very specific at the request of cardiology. So adrenal crisis. So with our care maps, we used to have one big shock care map. So just for ease for paramedics, instead of just having one to scroll down, it's like, yeah, this is great. We broke it up a little bit more particular to different crises. So one of them was adrenal crisis. So with adrenal crisis, the indications for this is suspected acute adrenal insufficiency in a patient with known chronic adrenal insufficiency or abrupt cessation of steroids. So if they've run out of medications, they don't have enough medications. But again, with this one, it's a patient with known chronic adrenal insufficiency. We're not just going to guess when we arrive on scene. It's going to be hard for us to diagnose them with an adrenal crisis if they've got no prior history at all. So some signs and symptoms, I get asked this a lot, what are some signs and symptoms of adrenal crisis when we arrive on scene and they're having adrenal crisis? It's like, okay, cool. So like, how do we check that? So the signs and symptoms, usually it's a patient that has, again, Addison's disease, they've been diagnosed with this, and they're experiencing symptoms of that along with shock. So a lot of these here is dehydration, hypotension, or shock out of proportion with severity of current illness. So they're just really hypotensive, and there's really no, like their input outputs are good. They're not bleeding. It's just, it doesn't make sense why they're hypotensive. And with that, they might have postural hypotension or dizziness. So when they sit up, obviously, if their blood pressure is low, they're going to drop. They might have nausea and vomiting. So that kind of ties in with dehydration as well, and a history of weight loss and anorexia, just meaning that they're not eating, they're not hungry. They might have an acute abdomen, so sudden onset abdominal pain, along with unexplained hypoglycemia. So they've got a lot of different things going on here. So again, any ultra C, if you're suspecting adrenal crisis, do a blood sugar, because we're going to have to treat that as well. If they just have a fever for no reason, it's just they're really febrile. So adrenal crisis causes loss of salt. So with that, they may have hyponatremia, so they're going to want a lot of salt. So if they're craving salt, that's a sign. And with that, because electrolyte imbalances, they may have confusion, psychosis, mania. And because this actually reduces urinary loss, they might be hyperkalemic, so they're retaining potassium. So it's not great for these patients. So contraindications to using the adrenal crisis care map is none. If they're not having adrenal crisis, we're not going to access this care map. So they're in shock caused by adrenal issues, awesome, but we're going to still treat it the same way. If they're not breathing, we're going to assist breathing. If they're having trouble breathing, we're going to give them oxygen. We're going to help stabilize and maintain their airway. So we're going to get IV fluid sooner, IV access right away, because again, if they're really sick, if they're starting to be hypotensive, we want to get an IV access so we can give fluid if we need to. And we want to give hydrocortisone. So the reason we give hydrocortisone to these patients is when a patient's having an adrenal crisis, their body creates a lot of vasopressin. And this really increases systemic vascular resistance and their mean arterial pressure. So in response to this, there's a decrease in heart rate and a decrease in cardiac output, causing them to go in shock. With that as well, like I said before, it has decreased urine output and smooth muscle contractions in the GI tract. So it can actually cause a lot of gastric motility issues, causing abdominal pain. And again, the electrolyte imbalances can follow that as well with decreased urine output. So by giving them the hydrocortisone, that can help them with their hyponatremia to correct that, as well as reduce the gastric pain because it's not going to have that gastric motility issues. We may have to give large fluid boluses to these patients, but again, every time you give fluid boluses to patients, keep reassessing them and give a bolus, auscultate the lungs, make sure we're not fluid overloading your patient, especially if they've got other things like renal issues, heart disease. We want to make sure we're not overloading them. So we might give them smaller boluses, but with these patients, you should be prepared to be giving larger boluses. So like I said before, they might be hypoglycemic with this. So we're definitely going to check blood sugars on our adrenal crisis patients as well. If you're going to have to choose between giving D10 and giving fluids for hypotension, I would recommend starting fluid therapy and then do your D10 because we need to get their blood pressure up, and dextrose is not a fluid that is to be used for fluid replacement for hypotension. So we need to get their blood pressures rising up so the brain is perfused. Then we can look at setting up our D10 as well. Again, if they're still moderately conscious, so it's like they have postural hypotension, maybe we can give them oral glucose while we're giving fluid boluses, but don't use D10 as a way to deal with their hypotension. That's not what it's for. And that's adrenal crisis. So again, a lot of these, if you're not sure, talk to the patient, talk to the caregivers, and when in doubt, call it out. So you can contact Online Medical and say, hey, this patient's presenting with this. Would this be a good candidate for hydrocortisone? So hypovolemic and septic shock is another one we separated. So with this one here, so with hypovolemic and septic shock, this one here, we have the traumatic care map, so major trauma. So, but we're like, we had a lot of contact with people saying, well, what if it's not traumatic blood loss? What if it's not traumatic hypotension? How do we deal with that? So with this one, it's shock suspected not due to hemorrhage, anaphylaxis, or adrenal insufficiency, or cardiac. So it's like, what's left? So with that, this care map is used for patients basically in distributive shock or fluid loss patients not due to hemorrhage. So we're looking at, like, especially with pediatrics, like vomiting, diarrhea, input-output imbalances, like they're very dehydrated because they've been stuck in bed and they haven't been able to eat or drink. So things like that. So contraindications, again, if they meet any other criteria for any kind of other shock care map or for major trauma, we're going to follow those care maps, not this one. So many of the initial steps in therapy for hypovolemic shock and septic shock are similar for pretty much all shock patients. So again, LSC, ABCs, make sure they're breathing, give them O2s as required. Big thing to keep in mind is that they're severely hypovolemic and they're severely hypotensive. You can't always trust your sat monitors because if you got on their finger or the new ones that go in their ear, poor perfusion, you may not get a good reading. So they might be reading low, you're not sure. So maybe not be a bad idea to give them at least a couple of liters nasal cannula while you're getting this all set up here. So if they are hypotensive due to distributive shock, just that vasodilation, you can start looking and giving large fluid boluses. But again, if there's any kind of issues with like heart disease, renal disease, we may be worried about overloading. So constantly keep rechecking your patient. And if you're going to give large fluid boluses, like if you're looking like you might be putting 2 or 3 liters in this patient, Ringer's is preferred over saline. The reason for that is Ringer's, and this kind of goes for trauma too, is Ringer's is more natural, is closer to the body's natural pH. And the other thing is when you have saline, it's sodium chloride. So if you're dumping lots of sodium chloride into our patients, that chloride can put your patient into hyperchloremia, which causes a decrease in pH. So we don't want to do that by giving them lots of saline. So we want to use Ringer's instead. So one way to determine that if your patient might be septic, so we have STIRS criteria. So this is just a way we can use our vital signs to determine if there's a concern for sepsis. So with that, they may have extremes of temperature of less than 36 or greater than 38. Heart rate will probably be tachy because they're sick, which is understandable. So greater than 90. There might be tachypneic as well, so greater than 20 breaths per minute. And as you have that increased breathing rate, you're going to be blowing out a lot of CO2. So this one actually has an arterial CO2 of less than 32. Arterial CO2 is usually 5 less than our end-tidal CO2. So basically for us, we're going to look at if it's like less than 37, so or the lower end of normal in the mid 30s. So with that, and that's going to be, we're going to use those vital signs because it does have white blood cell count. Those will do in the hospital. Obviously, we don't do those in the truck. So if they've had labs or anything recently, you can ask, has their blood cells been high? If you're doing an IFT, you could ask that. But obviously, we're not going to do that in the hospital. So to meets in the field. So if we have positive SIRS is 2 or more symptoms. So with that, if they're febrile with increased heart rate, then we can say they meet SIRS criteria. The thing is with that is that we're looking at SIRS. So they're responding to something is if they have more than 2. We're looking at sepsis if they have at least 2 SIRS criteria and presumed infection. So that could be a UTI, post-op, any kind of wounds that are presenting as infected. So those together, so it's sepsis. It starts turning into severe sepsis when you have sepsis plus organ dysfunction. So they haven't been peeing, things like that. So basically they're not functioning properly. And septic shock is when you have severe sepsis, so their kidneys aren't working and now they're hypotensive. So that's really bad news. So just to break it down there, that's how we're going to figure out if they're septic. And honestly, for us in the field is recognizing this, that's the big part, and fluid placement. Because again, if they're dehydrated, their kidneys aren't functioning properly, we need to get the kidneys going because we don't want our patients going to kidney failure because they're septic. Yeah, so honestly, this one for us, again, exclude hypoglycemia, all that good stuff. If your patient's severely dehydrated, again, try to get the ringers going first because, as I mentioned in the hypoglycemia care map, the D10 is a hypertonic and it will draw fluid out of the cells. So if they're already really severely dehydrated, we want to make sure that we're hydrating our patient by giving them ringers, and then we're going to follow that with glucose if needed. So now we have another care map for shock that we pulled out. So this one's hemorrhagic shock. So a lot of times we had this one come across as well for like traumatic hemorrhage. Like, well, what if it's not traumatic hemorrhage? What if it's like a post-op hemorrhage or an epistaxis or a GI bleed? So we created this care map to kind of give you options of what kind of hemorrhagic shock we're dealing with here. So obviously for indications, this is shock due to non-traumatic hemorrhage. So they're bleeding, but it's not from like a car accident, fall, stab, anything like that. So when we're looking at common sources of non-traumatic hemorrhage, again, we're looking at GI tract. So they're vomiting blood. They have like dark tarry stools. It might be epistaxis. You might have very heavy menstrual bleeding. So it's nothing to do with pregnancy. It's not postpartum hemorrhage, but they might have that heavy menstrual bleeding causing blood loss as well, because blood loss is blood loss. So just something to keep in mind there. So contraindications. So with that, again, so if it's lots of blood loss due to postpartum hemorrhage, we're going to go to the postpartum hemorrhage care map. If it's from trauma, so they got punched in the stomach, now they're bleeding, we're going to assume that's traumatic in origin, they're going to go to the trauma care map. So as always, IV, O2, give them fluids. But again, we always have to be careful, especially with GI bleeds or any kind of internal bleed. We don't want to just start dumping fluid because we still have to worry about that clotting cascade and diluting clotting factors. So when it comes to blood loss, yes, they need fluid, but we don't do it at the expense of just flushing all the blood out their system. So we have to be kind of careful with that. So we have that relative hypotension, so just maintaining a regular blood pressure. We kind of have to look at what's causing it, the blood flow, to determine if we want to do permissive hypotension or we want to just get them up to a normal blood pressure. The big thing we're going for is we want to keep the brain perfused. If they're maintaining properly the amount of fluid, we're pretty much good with that. We don't want to just overload these patients with fluid. So if we're going to go with the permissive hypotension, because if they have a massive GI bleed, again, if it's an uncontrolled bleed, we don't want to just dump lots of fluid, just like we would trauma patients, right? We're going to flush all their blood out. We're going to make them cold. We're going to affect clotting factors, all that stuff. So if you're going to go the permissive hypotension route, I took the vital signs here out of the trauma care map. So for adults, we want to maintain a systolic of at least, around 90, for adolescent 80, child 70, and infant 60. So we want to just give fluid boluses to keep them at that normal and keep the brain perfused, keep the kidneys perfused, and we just treat it accordingly. So we're going to consider TXA. We're going to call online medical for that because there are some things. We were going to put a big list in the care map of TXA works for this, TXA doesn't work for that. We're like, you know what? It's probably just easier if you phone it in. We can have a conversation. because there's still that time window for TXA needs to begin within 3 hours. And if they've been having like a epistaxis all night, now they're just tired and they're dizzy now, it's been like 6 hours, TXA may not be an option. Consult with the physician. Same thing with GI bleeds. If they've been like urinating blood for a couple days, TXA may not be an option either. So we want to have that conversation with the physicians where they're like, well, we could try it, see if it works versus not, based on studies and what their personal experience is. So if you're not sure, we're going to call it. And that's hemorrhagic shock. So again, a lot of times just some very similar to trauma, just blood loss is blood loss, but we want to make sure that we're not just giving TXA automatically. We need to contact online, and we're giving fluid carefully, because if they're, again, internal bleeding, we can't control that, and we don't want to just be flushing all their blood out their system. So for TXA here, the update to TXA was that the indications just changed to go along with what I just talked about there. So it's major trauma hemorrhage with or without signs of shock within 3 hours of injury, postpartum hemorrhage, or non-traumatic hemorrhage with signs of shock in certain situations. And again, certain situations, that's what you're going to call online medical for, instead of us putting this gigantic textbook of what to do for every type of bleeding. So for cardiogenic shock, so obviously this is a heart issue that's causing them to go into shock. So the indications for this is shock known or suspected to be due to cardiac cause. So common cause of cardiogenic shock are like having MI. Your heart's not pumping, it's dying. So that's obviously going to affect your blood pressure. They might have arrhythmias that aren't perfusing effectively. Also with that, we look at rates. Are they too fast? Are they too slow? So if there's really bradycardic, it's really tachycardic, that's going to affect your perfusion. So we're going to look at, is what's causing their their shock to kick in and their blood pressure to drop. It could be something to do with the mitral valve, some kind of myocarditis or a cardiomyopathy. So there's lots of different things. So basically it's anything that's going to affect the heart's ability to pump effectively. So contraindications, that is shock due to arrhythmias should be managed as per bradycardia, tachycardia. So like I was saying, that with that cardiogenic shock, if the heart is too fast, we have a care map to deal with that. If the heart is too slow, we have a care map to do with that. So don't go by this care map, go by the bradycardia, tachycardia care map as appropriate. So as always, oxygen, support their breathing, all that good stuff. And again, when you're doing your assessment if we're suspecting cardiogenic shock, make sure you also take the lungs. We need to hear if there's fluid in their lungs, because obviously if we're looking at hypotension, we're not going to dump a bunch of fluid in our patients if they're full of crackles in their chest. So we want to make sure we're also taking the chest when we do our assessment. Don't, give them oxygen. But again, if we're worried about an MI, as per heart and stroke standards, if they're not showing signs of cyanosis, respiratory distress, if they're above 90, we may not want to give them supplemental oxygen if we're suspecting MI, because that can actually increase cardiac damage. But obviously, if they're cyanotic, they're having trouble breathing, we're not going to withhold it either. So we just want to get a good standard. And it says in the care map there, 92 to 94% SATs. We're not trying to get 100% anymore. It's not non or breathe 15 liters, crank it 100% or nothing. We're just trying to get the patient's assisted breathing under control. So we're going to do 12 lead, just like we're going to see what's going on with the heart here. So put them on the monitor. Again, it could be a rhythm issue or a rate issue. That's why we're going to look at our other care maps if we need to, but we need to put them on the monitor first to see what we're dealing with. So if it says STEMI when we put the monitor on, we're going to treat them as we do with our ACS care map that I just reviewed. If not, we're going to look at giving fluid boluses, but we're going to give small amounts. So we're going to do 5 mLs per kg instead of like the usual 20. Because again, if the heart's not pumping effectively what it's already got in your system, more is not always better, especially if they're full of crackles in their chest. We may want to really be very careful with this, because we don't want to fluid overload the patient and basically drown them in IV fluid. That's really not going to help them. So make sure you're oxygenating the chest. Make sure you're doing constant reassessments, especially after each bolus. Reassess your patient, see how they're doing. If they even need more fluid, is that little top of all they need to get good perfusion? So we want to make sure we're checking all that. And then, of course, take them to the appropriate facility. If it is STEMI, again, we're going to contact the cath lab. If it's not, we can look at just going close to facility. But again, as per the care map that states, if Winnipeg's a close facility, this patient should probably go to St. B if that's available to you. That's cardiogenic shock. So this new one has been added in. So with our new trauma bypass, they want you to call the vectors physician regardless. So if you're within 30 minutes of Winnipeg, or HSC, I guess, they want you to contact vectors. If you're outside the 30 minutes and you call for trauma bypass, you're going to get it put in with the vectors physician and the STARS transport physician. So the reason that they want us to call in vectors, because it used to be if it was less than 30 minutes, we just go straight to HSC and just radio in. But they want us to contact the vectors physician because they can activate trauma teams. So this care map just kind of is to show you what the trauma teams consist of and why it's important we call it in so they can put the right team together for our patient. So part of it is HSC. It's part of for accreditation to maintain their status as a level 1 trauma center is to have trauma teams available and have that ability for us to activate trauma teams as appropriate. So different personnel will be included in these trauma teams depending on the activation level. So this will be on what we tell the physicians of what we're bringing in, what's going on, mechanism of injury, injuries to the patient, their status, things like that. So that's why we need to call in and like give vectors the heads up. So as much as possible, we're going to complete information that's required for trauma team activation and pre-registration for the trauma center or anywhere else. So with that, information required for activation. So we got things that the vectors physician is going to want to know. It's if you don't know, you don't know. It might be hard to give all this information while you're dealing with a very injured patient. I get that. But this helps them decide who's going to meet you when you get to HSC. So they're going to want your patient's age, gender, your mechanism of injury. Is it blunt versus penetrating? What's going on? Or is something still stuck in them? GCS, heart rate, blood pressure, basically all your vital signs. If you're going to give them a SAT, make sure you tell them if they're on supplemental 2 or not. If you're ventilating, make sure to tell them that. So if you tell them that their SATs are 98%, but we're actively ventilating with an IGEL in place, they're going to need to know that versus we got a nasal cannula on at 2 liters and they're setting at 98%. It's going to be a big difference there. So give them numbers. Don't just say it's all good. They're normal numbers. Like give them actual specific numbers. Obviously, if your patient has vital signs that are missing, such as they're not breathing on their own, just say vital respiratory rate 0. Just give them numbers. That's what they want. So tell them where you are. So your scene location, your estimated transport time, because it's going to be a little different if we're already en route versus we're just getting the patient out of the ditch right now. And how long you think it's going to take you to get to HSC. Again, brief just overview of what's going on with your patient and if you've done anything for your patient already. So if you've already got your TXA going, you're ventilating the patient, you got a pelvic binder on, you've tourniqueted their arm, they're going to want to know all that versus they have a lower leg fracture, but they were ejected. So it's going to be very different. So they want as much information as possible. So information required for registration. So I've talked to a few people and they find this really frustrating. Like, why do they want our FIN number when we're dealing with this patient's bleeding everywhere? That's just so they can pre-register. So you basically don't have to go through triage. You just walk in, they transfer them over, everything's set up by the hospital before you get there. If there's short transport times, it's forgivable. Obviously, if you're busy, you're doing stuff, and you might not have a FIN number because we don't have time to root through the patient's pockets because we're busy trying to keep them alive. So with this, if you don't have the info, that's fine. The patient's been to HSC before, they might have it on the computers when we get there anyways. So I see this more as a bonus information for them to help speed up the process at HSC. But again, if you're busy doing stuff and you don't have time to rifle through their wallet to get their FIN card, that's fine. Just do the best you can. So for this, like I was saying, they're going to want information to determine what type of trauma team they're going to attach to you here. So level 1, this is like everybody. So this is where vectors comes in because instead of just we show up red, HSC does an overhead page saying trauma team to resus 2, they will get all these people called in ahead of time. So hopefully they're there to meet you when you arrive so the trauma team is ready to go. So a level 1 trauma team based on your patient presentation will consist of an attending trauma surgeon, surgery resident, an emerge physician, so which will be the actual trauma team leader, second emerge physician for airway management. You might get residents, respiratory therapists, resuscitation nurses, and a clinical resource nurse. So basically they're going to pull everybody in. So with that, so for level 1, these are the criteria here. So these are more like your reference chart A in your trauma care map. So basically any major trauma. So with that, also if, like it says there for mass casualties, so they're starting to work down to this as well. If there's 3 or more major traumas expected, they're going to call everybody in, and then the trauma surgeons can triage who's going to go where when you arrive. So that's why we want to get all this staff in. So for level 2, they're not going to call everybody in, again, based on MOI, what's going on with your patients. So you're going to get trauma surgery residents, emergency physician as a trauma team leader. You're going to get emergency medicine resident. You're going to get nurses and clinical resource. So again, for this one, like we're not getting the RT, we're not getting the surgical attendant. There's not going to be as many people there because it's not as high level a threat to life and limb. So this is why it's important we get this information in so they can call the right people in, because if we have a level 1 patient and they've called the level 2 team in, they're going to have to start pulling everybody else in after the fact. So level 2, this one here, again, this is more the MOI anatomical factors, mechanism of injury. So again, I'm not going to read the whole list here. It's in the care map. So these are just reasons why they would call intact level 1 versus level 2. And that's trauma team activation. So thank you very much for watching the video here. Feel free to contact me if you have any questions, and thank you very much.